Hello, my name is Cordelia Alexander-Leeder, and I was a student intern with the Nevada Office of Suicide Prevention during summer 2017. My presentation today will cover the work I did and culminate my research. Today I will be discussing 2016 Regional Suicide Summary and Statistics. The agenda for my presentation today will be discussing my research methodology, general overview of suicide in our region, cause-specific statistics for suicide methods, regional suicide statistics, opportunities for prevention, missing information, and finally concluding with recommendations. My methodology consisted of utilizing Vertiq and paper case files housed at the Washoe County Regional Medical Examiner's Office. The case files contain medical records, the full medical exam report, and the full investigation. I utilized Excel to create an 86 data point database. For the purposes of the database, each death by suicide decedent constitutes one case. Once the data was redacted, cleaned, dichotomized, and a variable key was created, I utilized Excel and SAS to create graphs and figures. Regionally, there were 172 suicide deaths in 2016. The Washoe County Regional Medical Examiner's jurisdiction includes all Nevada counties, except Clark, White Pine, and Lincoln, as well as 5 California counties, Lassen, Plumas, Modoc, Sierra, and Alpine. Moving into a general overview, one can see that suicide is more highly concentrated in the older population, with 31.4% of regional suicide decedents being 66 plus. Nationally, while there are fewer suicides in younger age groups, suicide represents one of the highest causes of death for people below 44 years of age. Additionally, significantly more decedents are male, with 135 male decedents representing 78.49% and 37 female decedents representing 21.51%. According to the Suicide Prevention Resource Center, nationally, men die by suicide at a rate almost 4 times higher than that of women. 41% of decedents are married or in a serious long-term partnership, and 39% are noted as having children. Regionally, decedents are predominantly Caucasian, non-Hispanic, representing 83.72% of cases. Although nationally, it is reported that American Indian and Alaskan Natives have the highest racial disparity of suicide prevalence. The highest volume of suicide cases were noted in February and April of 2016. When looking at the distribution of suicide method by age group, one can see that gunshot wound to the head is prevalently utilized. 70% of decedents in the 66 plus age group had gunshot wound to the head as their cause of death. However, asphyxiation accounts for 60% of the decedents within the 10 to 17-year-old age group. When looking at distribution of suicide method by sex, one can see that male decedents more frequently experienced gunshot wounds to the head, whereas female decedents utilized mixed drugs intoxication as well as asphyxiation. Veterans and service members are consistently one of the highest suicide risk groups nationwide. Regionally, 16% of suicide decedents had some military affiliation, whether as veterans or in 2 cases as active service members. There is some research to suggest that employment status, especially recent retirement or termination, can be a precipitating event to suicide. I often found that this information was missing from case files. I could not find employment status for 51% of the decedents. However, employed represented 19%, retired represented 21%, unemployed 6%, and disabled 3%. Legal encounters can be an impactful precipitating circumstance. 13% of suicide decedents regionally had experienced a recent legal encounter. I counted decedents who were incarcerated at the time of suicide within this category as well. 3% of decedents appeared to be experiencing some recent financial problems, such as job loss immediately prior to suicide. According to the CDC, suicide rates are higher in more rural areas as well as western states. In Nevada, the highest suicide cause-specific death rate was in Pershing County at 59.58 per 100,000. Carson City came in next highest at 35.21 per 100,000. California's Lassen County was the highest at 22.68 per 100,000. For the purposes of these graphs, I counted the location that the suicide occurred in as opposed to the location the decedent died. There are many cases where a decedent commits a suicidal act in their home county and is then transferred to a hospital in another county where they subsequently die. I believe the more important information is where the suicide actually took place. 28% of decedents left a declaration of intent. Within these declarations and surrounding circumstance obtained through family and friends, a potential suicide rationale can be ascertained. For 76%, there is no obvious potential rationale. However, depression represents 15% and terminal illness represents 6%. In the 96 gunshot wounds, a semi-automatic handgun was used in 43% of cases. In the 45 asphyxiations, hanging was the suicide method used in 87% of cases. And in the 21 drug intoxications, prescription drugs were used in 90% of cases. 47%, or 80 cases, had a noted mental health history, and with 79% of those 80 cases diagnosed with depression and anxiety. Of those 80 cases, 34% had a medication treatment regimen, and 22% had a noted mental health care provider. 65 cases, or 38%, had a documented history of chronic illness, and 30 cases, or 18%, had a documented history of chronic pain. Within the case files, 11% of decedents had a history of hospitalization. 20% had emergency department visits, and 7% had psychiatric visits. 31% had documented some past suicide attempts, suicidal ideation, or both, and at least 28% had some length of hospitalization secondary to their suicide attempt or suicidal ideation. 28% had a history of addiction, and 58% of those cases noted addiction to alcohol. Only 11% noted receiving addiction treatment. 21% had documented health insurance. 57%, or 98 cases, had toxicology reports performed. Of those 98 cases, 42% had a positive blood alcohol level, and 29% were over the legal limit of 0.08. 23% tested positive for recreational drugs, and 37% tested positive for prescription drugs. While there were only 5 decedents within the 10 to 17-year-old age group, 60% had a history of adoption or living in foster care, and 40% had noted history of abuse. These precipitating factors must be considered by school counselors, teachers, and pediatricians who work with children. So now that we have all this information about suicide regionally, were there any opportunities to prevent suicide? I strongly believe that there were missed opportunities. 22% of cases had a noted care event with either their primary care provider, emergency department, or hospitalization within 1 month prior to suicide completion. 7 cases were seen at a hospital or emergency department within 48 hours prior to suicide, and 5 cases were seen by their primary care provider within 48 hours prior to suicide. This makes me wonder about what exactly is being lost in these provider-patient interactions, and it seems unacceptable. I believe that emergency room providers, hospitalists, and primary care providers must ask about thoughts of self-harm, suicidal ideation, and depression and anxiety at every encounter, especially when there is a documented history of mental illness, past suicidal ideation, drug and alcohol abuse, and terminal illness. I think there is a lost moment of intervention when this issue is brushed aside and not addressed compassionately and without judgment. Additionally, I believe follow-up calls within 10 to 12 hours of discharge for every suicidal ideation and suicide attempt patient should be mandatory. Many times, patients are discharged with instructions to follow up with a mental health care provider within 1 week. However, we can see that this time frame is too late for many patients. Finally, I believe more comprehensive resources should be provided at discharge, such as a step-by-step guideline for making a follow-up appointment and a list of suicide prevention organizations and crisis lines. Some information that I felt would be interesting or pertinent to suicide prevention was often missing or rarely documented. For future research, I would like to see better information and documentation on self-harm history, familial history of mental health and suicidal ideations or attempts, gender identity and sexual orientation, disabilities, profession and employment, school performance if enrolled in school, crisis line utilization, and social media usage. In the future, I believe a project like this would be better served by an intern who works on collecting more medical record information, such as prescription history and treatment plans, concurrently with new cases. I would like to see more detailed data collection by death investigators on the previously mentioned data points. And finally, I believe suicide prevention efforts could be aided by more detailed data collection from family members, friends, and people who interacted with the decedent prior to suicide. As time passes, I believe family and friends are able to start seeing clear red flags that in the moment they missed. Everyone has a role to play in suicide prevention, and it takes a community to end suicide. I would like to thank Misty Von Allen, the Suicide Prevention Coordinator, the Nevada Office of Suicide Prevention, Dr. Laura Knight, and the Washoe County Regional Medical Examiner's Office, and finally, the University of Nevada, Reno School of Community Health Sciences. My references are listed below. Thank you again for your time and consideration. Please feel at liberty to contact me if you have any questions or concerns.